Coronary artery disease is the most important topic on the PANCE, and rightfully so. It's got a lot of meat to bite into. But when it comes down to the PANCE, it's not about memorization and all these facts. It's about, hey, you have this patient in front of you. What are you going to do next? My name is Maruf, and in this video, we'll go over all the ins and outs of stable angina and ACS exactly the way the boards wants it. Let's dive right into it. When it comes down to it, coronary artery disease is just an umbrella term for atherosclerotic disease of those coronary arteries. Now remember that in general, you have lipids that are naturally found within your bloodstream, and over time, those lipids will find their way into your arterial walls, which allows for that plaque formation to occur. Eventually, as time passes, you're going to start to see decreased blood supply to that cardiac tissue as those plaques get bigger and bigger. Now, it's very important that for the PANCE, you know the risk factors for coronary artery disease because these are some of the most important clues that the PANCE will use to suggest that you're dealing with a coronary artery disease question like stable angina or ACS. So, for example, if you see your patient has a history of hyperlipidemia or obesity, which we know will increase the amount of lipids in the bloodstream, essentially allowing for more plaque formation to occur, then you should already start thinking that you're dealing with something like stable angina or ACS. Similarly, they'll use things like hypertension, which we know will increase the amount of shearing stresses on those vessels and therefore allow for more lipids to infiltrate. Or they might say the patient has tobacco history, where they know that the noxious inflammation of those coronary vessels will allow for more lipids to infiltrate into those arterial walls. Sometimes they'll say that patients have diabetes, which we know can cause glucose in the blood vessels to naturally find their way onto the walls and cause oxidative damage. Or they might just be older than the age of 50, which will just allow enough time for lipids to find their way into the walls and allow for enough plaque formation. Pretty much if your patient has any of these risk factors, you should already be framing your mind towards a coronary situation like stable angina or ACS. Eventually, these plaques are going to build up enough that your patients will start developing symptoms like chest pain. We call this chronic coronary syndrome, although the PANCE will still use the phrase stable angina. In stable angina, the plaque buildup is so significant that when the heart has to work harder, like maybe during exertion of walking up the stairs, the coronary arteries can't feed those cardiac muscles well enough. And instead, you get these transient episodes of ischemia of the heart, which will usually manifest as that classic substernal chest pressure. Now, usually these symptoms do resolve in about 5 to 15 minutes, since when you're at rest, that blood flow through the coronary arteries is still good enough. Some patients with coronary artery disease might actually experience an acute coronary event called ACS. In this case, that once stable plaque will actually rupture off, exposing all that gunky, gooey lipid core that was supposed to stay hidden. This will allow for this very highly inflammatory response, starting with platelets piling up against that core to cover it up, and then eventually clotting factors and other inflammatory cells. Basically, we don't need to know those guys. After all this activity occurs to quarantine that exposed lipid core, you'll start to see this massive thrombotic occlusion of that coronary artery. When that blood flow through these tight stenotic coronary arteries becomes so drastically decreased, that will cause symptoms even at rest for these patients. And that is one of the key signs of acute coronary syndrome, which is much easier or much worse symptoms than baseline. So when you have this critical occlusion of those coronary arteries, yes, the heart does gradually die, but it dies in a very specific pattern. What we find is that as you go from those superficial epicardial layers down to those deep endocardial layers, you actually have less and less natural blood flow as you go into those deeper layers. For that reason, when you have a massive thrombus form within a coronary artery, you'll find that the endocardium is one of the first layers of the heart to show signs of injury and ischemia. This is what we call unstable angina, where only that endocardial layer has started to die after that massive coronary thrombosis. Now, there aren't any specific proteins like troponin in this layer of the heart, nor are there any specific electrical activities in this layer that you're going to see, like maybe some ST depressions or T-wave inversions, but they're not very specific. So usually in these patients, they'll get diagnosed solely based on a good clinical story. As time passes, more and more of that heart will start to die, with the myocardial layer being the next layer to be affected. This is when we start to see an end STEMI. Now, since that myocardial layer is chock full of troponin enzymes, when that layer dies and starts to leak those troponin enzymes out into the bloodstream, you can actually detect that within your blood test. It just takes a few hours sometimes for those levels to actually rise appropriately. Just like that endocardial layer, the myocardial layer also lacks any specific EKG patterns when it's dying. Again, maybe some ST depressions or T wave inversions, but otherwise nothing specific to look for here. Now, eventually, if this thrombosis remains long enough, even that epicardial layer will start to die, causing an ST elevation MI or a STEMI. Now, some of you might remember that STEMIs are also known as transmural infarctions or infarction of all of the layers, which should make perfect sense to what we're describing here. Now, because the epicardium technically is fused to the pericardium, it does have the ability to generate very specific electrical injury patterns, which comes in the form of ST elevations. Now, technically, there are still troponins being leaked from that myocardium, but that's pretty old news compared to these new EKG findings we have, where we see things concerning for a STEMI, which is much worse. Now, whether you present with stable angina or acute coronary syndrome, both of these groups of patients will present with a very classic description of their symptoms. We call it ischemic chest pain or angina pectoris. Now, the hallmark description of angina pectoris is this classic substernal vague pressure that's usually worsened or brought on by exertion, such as shoveling or walking up the stairs. Now, often these patients will also have either nausea, sweatiness, or radiation of their pain, like to the jaw and to the shoulders, and those things should further increase your suspicion that you're dealing with some sort of stable angina or ACS. Now, sometimes patients can present with very atypical symptoms for ACS and stable angina. For example, instead of having that classic exertional chest discomfort, instead they might complain of GERD symptoms like epigastric discomfort, heartburn, burping, or sometimes they'll just have no symptoms whatsoever. Now, this is most commonly going to be seen in patients who are female, in those who are older, in those who are diabetic, and those who are obese. So obviously on the boards, it can be pretty difficult for them to test you on these kinds of things. They can't just throw an asymptomatic patient at you and be like, hey, figure this one out. So instead, they're going to use these risk factors like being female, being elderly, to cue you in that, hey, this is not just your simple GERD, this might be something more. For that reason, a good rule of thumb is if you have a patient that's coming in with chest pain or even GERD-like symptoms, but they have the risk factors for atherosclerotic disease, then this is a stable angina or ACS until proven otherwise. Now, once you've identified that classic angina pectoris pattern of chest pain, the next step is to determine if you're dealing with a stable angina or an ACS. We find that patients presenting with stable angina have symptoms that are pretty much the exact same as what they've usually had in the past. For example, that patient might complain of chest pain that occurs every time they walk up a flight of stairs, but this pain always has the same features every time. For example, it's the same intensity, it lasts for the same amount of time, etc. Now, this is completely different from what you'll see with acute coronary syndrome. When you have a patient coming in with acute coronary syndrome, they'll usually say that their pain is much worse than what they've ever experienced for their chest pain, or they might have never experienced chest pain before, and this is their first time experiencing that. For example, these patients might say that the intensity is much more than what they're used to. Maybe it's lasting longer than what they're used to, or maybe it came on with very minimal exertion. Now, whether you're dealing with stable angina or acute coronary syndrome, as soon as you identify a patient with angina pectoris symptoms, the next step is always going to be an EKG within 10 minutes. And of course, troponin enzymes, but that EKG really is going to be the most important component. Even if it sounds like a slam dunk stable angina, you just never know if this patient is instead having ACS. And that's why you got to check those EKGs and troponins first to disprove that. This holds true for both the boards as well as for clinical practice. Now, if the boards are trying to steer you towards stable angina, then they will usually give you a very classic presentation of stable angina with symptoms similar to prior. Remember, that's the most important component. And even sometimes they'll give you a normal EKG and a negative troponin to tell you, hey, we've already ruled out ACS for you. Only then can you say that stable angina is your leading diagnosis, and then your next step would be to perform a stress test to confirm that diagnosis. Now, of course, if you see those classic ST depressions on EKG, when the patient is exerting themselves on that stress test, then this will clinch your diagnosis of stable angina. At this point, you can move forward to medical management, and that will be in the form of a beta blocker as your first line management and an aspirin as a preventive management. Now, beta blockers will decrease the amount of cardiac activity, so even during times of exertion when the heart would normally rise in its heart rate or in its contractility, the beta blocker will keep that amount of cardiac activity low, therefore not allowing that heart to overwork and cause that chest pain. In addition to a beta blocker, every patient should ideally be started on an aspirin to prevent future possibilities of an acute coronary syndrome. Remember that in ACS, there's a plaque that ruptures and you get that ooey gooey core that gets revealed. But the first thing that happens when you reveal that core is that platelets start piling up. So it makes perfect sense that a daily aspirin would be a great addition to stop that ACS right in its tracks by stopping the first step in its process. I like to think of metoprolol as the key player to keep your patient nice and comfortable, but aspirin is kind of like a bodyguard that keeps it safe from the grips of acute coronary syndrome. Now, these patients would also be started on atorvastatin to control their lipid levels, as well as nitroglycerin that they can take whenever they have breakthrough chest pain, but these medications aren't as impactful in stable angina as is a beta blocker and aspirin. Now, I'm sure many of you are familiar with the concept of percutaneous coronary intervention, or PCI, also known as a cardiac catheterization. That's basically where you go in with a catheter to the patient's coronary arteries, dilate a balloon to squish all that plaque out of the way, and then deploy a stent to keep that vessel open. Now, for the sake of the PANCE, you will hardly ever take a stable angina patient for PCI and stenting. This is going to be exclusively reserved for patients who continue to have episodes of chest pain despite being on those appropriate medications like a beta blocker and aspirin. In these cases, it makes sense to go in and try to stent that coronary artery as a definitive management for the patient's disease. Now, I'm sure some of you have also heard the phrase CABG, or coronary artery bypass grafting, where you take a vessel from somewhere else in the body and use it to connect the aorta to a segment of the coronary artery that is distal to that occlusion, essentially bypassing that obstruction. Now, in reality, the ins and outs of CABG are just much more than what you actually need for the PANCE, but I would just remember these two things. If a patient has a coronary artery disease of their left main coronary artery, the biggest coronary artery we have, then those patients probably need a CABG. Similarly, if you have a patient who has multi-vessel disease, like 3 or more, and they have a history of diabetes, that's a lot of disease, and again, these patients are more likely to benefit from a CABG. Now, if instead of a patient with very classic stable angina symptoms, you instead see these symptoms are much worse than their usual pain, or maybe just new altogether, you should presume you're dealing with an acute coronary syndrome until proven otherwise. Now, just like when patients have symptoms of stable angina, the next step for ACS is still the same: EKG and troponins, with EKG really being that most important part. Now, technically, this is where it can start to get a little complicated, so just bear with me. If that EKG shows ST elevations or a new left bundle branch block, then this is a STEMI until proven otherwise. Now, of course, these ST elevations do need to be in contiguous leads, but I'll refer you to my EKG video for more on those EKG features of STEMIs. We'll just keep it moving. Now, STEMI management is pretty straightforward because the most important answer is going to be PCI, or percutaneous coronary intervention, ideally within 90 minutes of them arriving to that ER. By going into that artery and deploying a stent, you effectively remove that obstruction and allow for the heart to be fed again. Now, of course, if the hospital doesn't have a cath lab, then you can do fibrinolysis as like a subpar alternative, where you'll use a medication like TNK, which will break down clots all throughout the body. And yes, that'll be including the obstructive clot within your coronary artery. But you have to remember that you also make tiny little clots all throughout your body too, and it'll start to break those up as well, and could potentially lead to some very significant bleeding. So PCI is the best answer, but if the question stem says the hospital doesn't have a cath lab, then you're going to choose fibrinolysis as your next best step. Now, keep in mind that when we're talking about STEMI locations like anterior, inferior, technically we're always talking about the left ventricle. Our standard EKG does not look at the right ventricle. However, we do see that about 50% of patients who have inferior left ventricle STEMIs will also have technically a right ventricular STEMI as well. Therefore, if you see ST elevations in those inferior leads, then you should automatically presume that you're dealing with a right ventricular infarction as well. The right ventricle is very preload dependent. It needs a constant return of blood from the systemic circulation in order for it to function appropriately. So when that right ventricle suffers a STEMI, it needs even more preload to keep itself alive. So much so that these patients often become hypotensive when they have a right ventricular MI. Putting all this together, it should make perfect sense why you should absolutely avoid nitroglycerin in these patients. And remember that nitroglycerin is going to cause vasodilation of all your veins, meaning that more of your blood will stay in the venous system and less of it will actually return to the heart. That decrease in preload will take this already injured right ventricle and kill it much faster. So instead, these patients often need IV fluids to help preserve that preload and therefore preserve that right ventricle. Now, the most common way that the PANCE will test you on right ventricular infarctions is going to be by presenting a patient with, again, an inferior ST elevation MI and asking what the next step is. But while most of you would say, oh, PCI, they will not put PCI as an answer. Instead, you'll see IV fluids as one of the answer. That is the one you're going to choose, and definitely do not choose nitroglycerin. Now, if the EKG doesn't show any ST elevations, and again, it can show anything like ST depressions, T wave inversions, I don't care. As long as there are no ST elevations, then you should assume that you're either dealing with an NSTEMI or an unstable angina. Now here, the next step is to look at your troponin results to determine which of the two you're dealing with, where a positive troponin will indicate an NSTEMI, while a negative troponin will indicate an unstable angina. Now note something very unique about unstable angina. There are no troponins and no EKG changes. All it takes is a good story of angina that is new or worse, and you automatically have unstable angina as your diagnosis at a minimum. You then upgrade this diagnosis based upon the EKG and troponin findings, where if it's positive troponins, you're upgraded to an NSTEMI, or if you see ST elevations, then boy, you got a STEMI. Here again, whether you're dealing with an unstable angina or an NSTEMI, the treatment is the exact same if there are no ST elevations on that EKG. The most important thing that I need you to grasp here, there is no emergent PCI for these patients. Only STEMIs get emergent PCIs. NSTEMIs and unstable angina just get medication and only medication. Now that first medication should be aspirin, since it is very fast acting and it's going to directly inhibit those platelets that we talked about from aggregating on that exposed lipid core, in turn stopping that thrombus from getting bigger and bigger. Now the PANCE usually doesn't care much more beyond this part, but you should technically give the patient a second antiplatelet agent as well, like ticagrelor or clopidogrel, as well as an anticoagulant like Lovenox or heparin, since all of this in combination will work much better than aspirin alone. Eventually, you should also start the patient on a beta blocker to decrease that cardiac work and preserve those cardiac muscles, and statin to decrease that future plaque buildup. One of the PANCE's favorite ways to add a little spice to the mix is by adding a splash of cocaine to your ACS questions. So far, we've technically talked about only atherosclerotic causes of ACS. In other words, those that are related to plaque buildup. But when it comes to cocaine, it's usually not a plaque issue. These guys will have a vasospasm of their coronary arteries, and this can result in very similar events like unstable angina, NSTEMI, and even a STEMI. Note the difference here though. Instead of a plaque rupture, like we see with the atherosclerotic diseases, here you're getting a vasospasm of those coronary arteries. This is going to significantly reduce the blood supply to the heart, causing in turn an acute coronary syndrome. Another difference you're going to see here is that instead of an older patient with those atherosclerotic risk factors like hypertension, diabetes, instead you'll be presented with a younger patient with really no risk factors who still describes that classic chest discomfort for ACS, either something new or something worse than prior. Now, for all intents and purposes, your next steps will be the exact same as if you were dealing with an atherosclerotic case of ACS. And that's just because people who do cocaine can still have atherosclerotic disease and therefore still require the same interventions as what we talked about earlier. So if you have a question presenting a cocaine user with chest pain, your next step should always be an EKG and troponin still, and your initial treatment should still be aspirin or PCI based upon what that EKG and troponin show. No difference here. We're going to keep it the exact same. Now, the only thing you're going to do different is that you are not giving a beta blocker to these patients. Remember that cocaine doesn't just cause vasospasm of those arteries, it also jacks up the heart and makes it beat very hard and very fast. If you use a beta blocker, yes, you do block the cocaine from binding to the heart's receptors. That just means that the cocaine has nowhere else to go but those coronary arteries. This is what we call an extreme level of vasoconstriction known as unopposed alpha 1 vasoconstriction. This will essentially rob the heart of its blood supply, leading to rapid death. Now, sometimes these questions will indicate a cocaine-induced chest pain, but indicate already having a normal catheterization. Keep in mind that only once you've disproven atherosclerotic disease can you call this a true cocaine-induced ACS. And only in these situations, after you have a negative cath, can you treat them with benzodiazepines like Valium to just treat their symptoms. Now, just when you thought having a heart attack was bad, just know that it can always get worse. For example, patients might go into straight up ventricular fibrillation since dead myocardial tissue is very arrhythmogenic. Now, we do discuss VFib in my EKG video, so I'd recommend you check that video out for more information, but for now, we're just going to keep it moving. Now, instead of conduction abnormalities, patients might instead go into structural abnormalities, like, for example, acute decompensated heart failure, where that heart is dying, those muscles are dying and losing their ability to contract, and therefore they're not able to push blood in the forward direction. Instead, all the blood will back up, like to the lungs and other preceding organs. Now, these patients will usually be presented as having ST elevations to indicate a STEMI, but then all of a sudden, while you're assessing them, they'll develop rales on auscultation or pulmonary edema on chest x-ray. This suggests the presence of a decompensated heart failure as a complication. Now, sometimes the heart's contractility is so severely reduced that it can actually go even further into cardiogenic shock. Here you have the same symptoms of shortness of breath, rales, pulmonary edema, but you'll also now have hypotension because that's how low that contractility has become. Now, if there's one complication I would make sure that you know, that would be papillary muscle rupture. The boards loves this one. After an MI, the papillary muscles undergo slow inflammation and death, and that can lead to a rupture of those papillary muscles after a few days, usually like 3 to 7 days. This causes the patient to develop an acute mitral valve regurgitation because the mitral valve loses its integrity to actually close properly. Now, while chronic mitral regurg isn't dangerous, acute mitral regurg can be, because in combination with those dead, weak heart muscles from the STEMI, in combination with the blood now flowing backwards due to acute mitral regurg, this is going to cause the patient to go into decompensated heart failure and eventually cardiogenic shock, just like we talked about before. Now, these patients will again sound exactly like those previous patients, but in addition to the shortness of breath, the rales, the pulmonary edema, maybe even the hypotension, they will also have that iconic, loud holosystolic murmur that we know to be true for mitral regurg. So if they provide you a patient who had a STEMI a few days ago, and then these patients are developing shortness of breath and pulmonary edema with a new holosystolic murmur, you should immediately think papillary muscle rupture. Now, in these patients, the next step will still be to stabilize their heart failure or their cardiogenic shock, and then perform an echocardiogram to confirm that diagnosis that those papillary muscles are actually ruptured. Now, we can keep going for days when it comes to ACS, but we've definitely gone over the most important concepts that you need to know for the boards. So before we wrap up, make sure you can answer all these questions with confidence, or go back to the video to clarify any questions. Meanwhile, while stable angina and ACS are going to be the most important topics that you need to know for the boards, they're certainly not the only things that can cause chest pain. So we'll continue our chest pain module next with pulmonary embolism. I'll see you there.